I'm Annemarie Thompson, and I'm a professor of anesthesiology, medicine, and population health sciences at Duke University, where I practice cardiothoracic anesthesiology and critical care medicine.
My name is Kirsten Fleischman, and I'm a non-invasive cardiologist and an outcomes researcher. I'm also a professor at the University of California, San Francisco, where I serve as an assistant chair in medicine and associate chief in cardiology, and as a medical director, specifically of our adult cardiac stress and ECG laboratories at UCSF Health.
My name is Nathaniel Smilowitz. I'm an interventional cardiologist and clinical investigator and assistant professor at the NYU School of Medicine in New York, as well as the VA New York Harbor Healthcare System Manhattan campus.
What do you think are the most important or maybe surprising in the take-home messages that clinicians should know until they get around to reading the entire document?
I think there are several key takeaways, but certainly one of the takeaways from this guideline is that cardiovascular screening and treatment around non-cardiac surgery should generally adhere to the same indications as non-surgical patients, with an emphasis on trying to avoid over-screening and over-treatment. For example, the guideline advocates for using stress testing judiciously in those undergoing non-cardiac surgery, especially those at lower risk, and generally only in those in whom testing would be appropriate anyway, independent of the planned surgery.
Is there anything else that you think about or that you think are points that clinicians should pay close attention to in the guideline?
I think the medical management also warrants sort of a new consideration. So this guideline highlights the new therapies for the management of diabetes and heart failure, the sodium glucose cotransporter 2 inhibitors, which can cause ketoacidosis in the perioperative setting. And so while many of our patients are taking these drugs, empagliflozin or dapagliflozin or other agents in the class, it can have adverse effects in the surgical setting. The new recommendation is to withhold these drugs 3 to 4 days prior to non-cardiac surgery to avoid the risk of perioperative ketoacidosis.
I think one of the take-home messages that really stuck out to me was the need to pay attention to atrial fibrillation and stroke. And in particular with stroke, there is a U.S. study as well as an international study that looked at the timing of surgery after stroke. And it's one of those cases where the sooner is definitely not the better, and perhaps pushing that out at least 90 days could prevent further morbidity from stroke.
Transient perioperative atrial fibrillation is also something that really can't be ignored. Even when it's just a few hours of postoperative atrial fibrillation with a return to sinus rhythm, that patient is at increased risk for stroke over the long term. We now know that those patients need to be monitored carefully in the outpatient setting and considered for antithrombotic therapy long term.